Hi, I'm Mark Conaggiani. I'm the Director of Adult Treatment and Recovery for the Office of Behavioral Health. The Office of Behavioral Health, in collaboration with the Colorado State Innovation Model Grant, has developed 3 training modules around the topic of substance use disorders. This module on opiate use disorder is connected to the substance use disorders introduction module and the expert module. We highly recommend that you watch all 3 videos to ensure a comprehensive understanding of integrated whole patient care related to substance use and substance-induced disorders. One of the most pressing issues facing healthcare today is the identification and treatment of opiate use disorder. We recognize the need to equip the medically trained members of the integrated primary care teams to screen, assess, and treat or refer patients of all ages for issues related to opiate use. Our goal in this video is to examine the value and importance for the medically trained primary care team members to address opiate use disorder during a patient encounter and provide tools to help you move efficiently through this process. We will discuss key points related to screening and assessment, options for treatment or referrals, and accommodations for differences between children, adolescents, adults, and seniors, as well as any similarities.
Hi, I'm Rob Valek. I'm a professor of family medicine, pharmacy, and epidemiology at the University of Colorado Anschutz Medical Campus. I think it's important that we talk about the value to integrated medical and behavioral health care practices to assess, identify, and refer patients that have opioid use disorders. The use of opioids in the United States is very high. About 10% of the population at any time is taking an opioid for some indication, most often for chronic pain or one of the chronic pain syndromes. Acute pain is also being treated with opioids, for example, post-surgical pain. On occasion, people do become tolerant, dependent, or addicted to their opioid therapy, and we as healthcare professionals have a responsibility to identify them for treatment and possible referral. It's estimated that 1 to 2% of all Americans have an opioid use disorder, where they're not only tolerant and dependent physically, but are now engaging in behaviors that have negative consequences to themselves, their own health, and those around them, like their family, friends, or community. Their tolerance to the drug has progressed to a diagnosable opioid use disorder. The DSM-5, or Diagnostic and Statistical Manual of Mental Disorders, 5th revision, tells us that opioid use disorder is a clinical diagnosis and not just a suspicion about drug-seeking behavior. It's a disorder that we need to identify in our patients and treat. As a member of a primary care team, we need to prescribe opioids safely, which means only the minimum amount necessary for both dose and duration. We talk to our patients about safe use and storage of the medication and why they don't share them with anyone else. Safe use, safe storage, and safe disposal of opioids are the primary messages. Please visit the Take Meds Seriously website at takemedsseriously.org for more details on these options. In terms of safe storage, some practical advice that you can give your patients is to view the opioid prescription as something that's potentially very dangerous if a child or a friend or a neighbor gets a hold of it. We recommend that people purchase a safe or a small lockbox to lock up their prescriptions if they're going to be on chronic opioid therapy. Or patients can simply put the opioid prescriptions in a place that is hidden to family members or friends, such as a closet in a very specific place that only the patient would know about. For safe disposal, if there are any tablets left over, they should be safely disposed of and not kept. We recommend people do not flush the medications down the toilet anymore because of the environmental concern. They can look for the nearest Colorado safe disposal location on the takemedsback.org website or call their local pharmacy. There are many locations around the state of Colorado where patients can take back their extra opioids. I encourage my patients to safely dispose of any unused opioids, and if they suddenly need some more, they can come back to me. We will reassess their pain and give them more if they need them. A patient should not be scared that if they get rid of their medication, they won't be able to get another prescription. We are never upset by this. It's also important to know that in integrated primary care, We treat patients with a whole host of different presentations and diagnoses. Many of them are behaviorally health-oriented. Depression and anxiety are very common. Comorbid depression, anxiety, sleep disorders, and pain, those 4 conditions rarely exist in isolation. It would not be a surprise if someone with chronic pain also reported some amount of depression, anxiety, and probably some sleep disorder. We need to make good measurements of the pain, the frequency, intensity, and burden of the pain, all of the major dimensions that we were taught in school about pain and how to assess them for proper treatment. We can work with our behavioral health team members as colleagues to not only identify those behavioral health issues, but also to potentially identify substance use disorders like opioid misuse and use disorder. Our behavioral health colleagues are very good at this, and they can work together with us in a team orientation to assess what's going on with a patient. The evidence is clear that team-oriented, multidisciplinary care for pain and managing opioid use disorders is much more effective with both medications and behavioral therapy delivered together by an integrated team. Assessment, identification of problems, and then, if needed, referral to treatment are all important. Much of it we can do as integrated primary care teams. We can learn to do medication-assisted treatment for opioid use disorder. But if not, then we need to be aware of our referral resources and how to do a warm handoff of a patient to a colleague who does medication-assisted treatment. Some readily available tools you have at your disposal include the State Prescription Drug Monitoring Program, or PDMP. This tool will assist you in determining if the patient might be obtaining opioid prescriptions from multiple physicians or multiple pharmacies. If they are, that can be a potential indicator of misuse or opioid use disorder. You or one of the members of your practice team need to check the PDMP prior to determining your treatment plan and whether or how to prescribe an opioid. You can also use various risk management techniques for people at high risk. For example, those taking a very high dose of an opioid for chronic pain, or if somebody is an injection drug user, or someone with asthma or COPD that puts them at higher risk of an opioid-induced respiratory depression, leading to an overdose. For any of those high-risk situations, we can prescribe naloxone for a patient along with the opioid, so they have a reversing drug available to them. We can provide information about how to access syringe or needle exchange harm reduction programs. Because not only is it important to keep people alive, it's important to prevent the spread of communicable diseases like hepatitis C or HIV. If patients have clean syringes and needles, they can prevent the transmission of those communicable diseases. We know that opioid use disorders do not discriminate. You can't look at a patient and determine from their age or name or gender, their socioeconomic status, race, ethnicity, or the region that they're from if they have a high or low likelihood of opioid use disorder. Everyone is at risk. We believe a universal screening approach is the best approach. For anybody coming into our practice, we include brief screeners like SBIRT or the DAST or CRAFT tool specific to substance use disorders, and then a very brief screener like the PHQ-2 or the PHQ-4 to screen for depression and anxiety. In that way, we know we'll be doing a much better job of identifying behavioral health issues like anxiety and depression and substance use disorders in our patients. And then we can do a brief intervention based on readiness or a referral to treatment if something more involved is needed. We build this in as a universal precaution for all patients, so we don't have different ways we do things for different patients. It makes things easier and much more efficient. It's important to consider the available pharmacologic treatment options for both pain management and for treatment of opioid use disorders. For treatment of pain, opioids can be appropriate for certain patients and certain circumstances. At the same time, there are a lot of alternatives that are just as effective or more effective than opioids. For example, acetaminophen and ibuprofen can be used every 4 hours in rotation for relief of many pain conditions, such as dental procedures or minor post-surgical pain. Other options include things like certain antidepressants, certain GABAergic drugs, various non-steroidal anti-inflammatory drugs, and even drugs like Bentyl or Haldol can be used for pain in certain circumstances. There are also a number of options if somebody happens to have an opioid use disorder. 3 primary drugs are available for medication-assisted therapy: methadone, buprenorphine, and naltrexone or Vivitrol. Each of those is available and appropriate for use with certain types of patients based on their diagnosis, how long they may have been opioid dependent, which drugs they may have been using, and what your therapeutic objectives are. It's important to be aware of these drugs and learning how to prescribe them. As much as we want to develop good referral networks, we also need to be training ourselves to prescribe buprenorphine or naltrexone for some of our patients, because the wait times for treatment programs can be very long. We advocate doing both: provide medication-assisted treatment and make the referral. Know your treatment resources and referrals, and start to train yourself in primary care to do medication-assisted treatment. There are some differences, of course, between children, adolescents, adults, and seniors related to opioid use. Often these differences are found in the way that people are embedded in their social and family networks. For example, if a child or adolescent comes from an environment where they have a family unit at home, and we know the degree to which that family unit is intact and well-functioning, we can correlate how well that environment will support or detract from how well the patient is going to do. It's extremely important to know about an adolescent's family and social situation, their school situation, their academics, and their socio-demographic characteristics to find out what supports they have in place. The person may be managed in terms of pain or substance use disorder on the one hand, but without knowing about the patient's social and family network, it's very difficult to provide the best care. Adults have a unique set of demands with professions and work environment, social and behavioral interactions with others, and those sorts of stressors that usually go with employment, underemployment, or unemployment. The elderly have 2 primary differences. One of them is social isolation, which is increasingly common and often correlated with behavioral health issues like depression and anxiety. And as we age, we have different health needs, such as developing arthritis or developing hypertension. Those things are more common, and it makes treating our senior patients more complex. Each patient needs to be screened and considered on an individual basis to determine their unique circumstances when determining pain management plans and when assessing potential opioid-related issues.
Opioid use and misuse is avoidable across most patient demographics. Intentional, responsible, and proactive patient care can turn the tide in this national crisis. There are 2 key areas for impact. First, the prescribing team members must be aware of their options when working with patients and pain management. The second opportunity is through accurate and effective screening, identification, treatment, or referral of patients experiencing opiate-related health issues. There are 3 medications that are FDA approved to treat opiate use disorders. Methadone maintenance can only be offered through specially licensed facilities. Buprenorphine or depot naltrexone could be provided by you or other prescribers in your practice. If you do choose to treat a patient's pain with an opioid medication, co-prescribe naloxone. Don't try to determine if your patient is likely to misuse or overdose on the medicine you prescribe, but use this as an educational opportunity to demonstrate the risk that the medicine creates simply by being in the home. Explain to your patients or their families how to identify signs of an overdose and how to respond by administering naloxone and calling 911. Your message about safe storage will resonate more strongly. Changes in policies and regulations related to opiate use are developing daily. For example, the Department of Healthcare Policy and Financing announced on July 10th of 2017 it is tightening its policy in prescribing and dispensing opioid pain medications to Health First Colorado members or Colorado's Medicaid recipients. The new policy will be implemented in 2 phases. The first phase is effective August 1st, 2017, and limits the supply of opioids to Colorado Medicaid patients who haven't had an opioid prescription in the past 12 months. The second phase of the policy will reduce the daily morphine milligram equivalents, or MME, for members currently on a pain management regimen. Beginning October 1st, 2017, the total daily limit of MME will be decreasing from 300 MME per day to 250 MME per day. For ongoing updates, check the resources list that is provided with this module. Misuse of prescription medication across the country and here in Colorado has led to an opiate crisis that has now extended to increased heroin use. Your medical team and the practices you adopt can prevent your patients from developing an opiate use disorder. With consistent screening practices, your early identification of problematic use can help your patients avoid further problems or help them get specialty care if needed.